morning, everybody. Thank you very much for making time to join us for this wonderful Sunday morning. A little bit of sharing at the end of October. So me and I'm Prof. Aisha from University of Malaya with Dr. Yolanda all the way from the UK. Would like to welcome all of you to join us this morning. Yolanda, please just jump in, okay? But maybe we want to share why we are doing this today, yeah? So we can see today we will have a very lively session with so many people. People cannot believe that we will finish this in 1.5 hours. But we have 3 segments all prepared for you. The first segment is highlighting the stories from east to west of Malaysia, citizens and non-citizens of Malaysia. And segment 2 is talking about how we can narrow the gaps of these challenges that our women are facing today. And segment 3 is where we have Yang Berhormat Nurul Izzah, who will be with us today, where we lawmakers and NGOs, how do we work together? So a bit of on the spot starting point, where titik permulaan selepas Oktober dalam Kenangan. So let's start first why we're doing this. So
it's 10 o'clock.
You can see we have the world is now pink. So this is the latest World Cancer Incident Report by the Global Can that shows that breast cancer has overtaken all the other cancers for most of the country as the top cancer of that country. Previously, you used to see this is blue. Blue is lung cancer. And now it's all pink. So breast cancer indeed is an index case cancer, a most important cancer. And if you can solve issues around breast cancer, we could probably solve issues around many other cancers as well. So the Global Breast Cancer Health Initiative, which is a WHO initiative, came up with this plan that was launched on World Cancer Day, where the main target really is to reduce breast cancer mortality by 2.5% per year. And this saves up to 2.5 million lives by 2040. So this is the target for the world globally. We need to reduce premature mortality to save all these lives because it can be done. So the WHO has come up with 3 pillars. The first pillar is health promotion and early diagnosis. The pillar 2 is timely breast diagnostics, and pillar 3 is comprehensive breast cancer management. So this is all the WHO initiatives related to cancers. So we have the elimination of cervical cancer, we have the childhood cancer survival targets, and now we have the WHO Global Breast Cancer Initiative to reduce premature mortality due to this disease. So in Malaysia, breast cancer is the commonest cancer. And I'm not talking about men or women. These are all cancers. So 90% of all our cancers in Malaysia is breast cancer. But unfortunately, we know Malaysia actually has a very low survival rate compared to the other countries around our region. In Japan, 5-year relative survival rates can come up to about 88%. And in Singapore, it's about 80%, but in Malaysia, we only have about 66.7%. So the budget has been tabled and we're all excited. However, we know we are not putting enough resource into health for Malaysia. We have about 4.3% of our gross GDP, domestic product, and only 4.3% of this is spent on health. And out of this 4.3%, only half is spent by the government. So essentially, it's only about 2%, maybe 3% of the GDP is spent on health. So if you look at the distribution of the total expenditure on health, 45% is spent by Ministry of Health, 35% is actually paid by private households, and this is out of pocket. And insurance only make up about 8%. So these figures are scary because you and me, without insurance, without a very strong health system, we may find that we do not have access to treatments. So this is just the same thing. And I would like to put this up. People wondered why this year Together Against Cancer is really focusing east to west. And my chance meeting with Dr. Yolanda has brought us together because we know in Malaysia there is a massive disparity between east and west. And we know in the eastern coast, Malaysia, Sabah and Sarawak, the coverage even for essential surgery, and this is just life-saving surgeries, is only 73%. So that leaves something like 1.8 million residents in Sabah, Sarawak not having timely access to essential surgical services. And this is published by our Tan Sri Datuk DG Hisham this year. So please, there are some references there. This is a very important information for us. So without further ado, I would like to invite all our speakers for the first segment. We have Ms. Cecilia, Ms. Crystal, and Ms. Deborah. Are you all here? So first, we'd like to listen to the stories of carers, the women who support women, the family that support women with breast cancer. Maybe Ms. Cecilia, are you there? Can you hear me?
Hello, I'm here. Yes, Professor,
okay.
Good morning. I'm here.
Yeah. So I think we will leave the floor to you because we have a very short time. Would you like to start your sharing about what happened to you and how people should learn about this story?
Okay. Good morning, everyone. My name is Cecilia Siti Una. I am a retired nurse. I'm now a full-time volunteer community champion focused on healthcare programs for women and children in Sarawak, particularly in the rural communities. I am also a Know Your Lemon educator, a program aimed teaching the community women how to do self-breast examinations and maintain breast health. The Know Your Lemons in Sarawak. We currently having 15 women of Sarawak also undergoing training throughout the Know Your Lemons educator program. We currently use the Know Your Lemon material in Malay for our education session, but as in the process of translating the material into our local Sarawak dialects, such as Iban, Bidayuh, and Orang Ulu as well. I just want to take this moment to also mention this Persatuan Kebajikan Sejahtera Kuching, that's where I am now, which I'm part of it, and through which as women in Kuching also carrying our community outreach program work. The Persatuan was founded by Yang Berbahagia Datuk Sri Ajah Hafsah Harun, who is herself a cancer survivor and a great inspiration and champion of women empowerment in Sarawak. Thank you, Datuk Hafsah. I'm sure she is here listening to us this morning, for mentoring and empowering us women and focus on cancer screening for women in Sarawak. I grew up in a long house where life was simple and we were closely knit. The spirit of sharing the harvest and whatever we have, the togetherness as well as this, are very strong within our community in the Longhouse. However, let me share, unfortunately, cancer remains a taboo subject, and many cancer patients suffer in silence and hide their signs and symptoms for many months and sometimes even years. Due to the lack of healthcare education, cancer is still sometimes considered as a curse. If a woman discovers breast lump and possible cancer, often she will hide it from others, including the family members, even her husband. These are taboos, and that we desperately need to break the attitudes that we need to change with the community outreach and education among both women and men as well. Back to my past career as a health nurse, I graduated at the age of 22. My job scope was delivering healthcare to rural communities. I would travel by road, river, as well as helicopter to the various districts and the remote areas through the Flying Daughter service. At night, I will giving the health education talk where I will get closer to the livelihoods of the community in the remote areas, and mainly on immunization as well as hygiene. For the women, I would like to teach them self-breast examination. However, some of the women would still be shy. How I wish at that time I had known this Know Your Lemons model. That would be have been so good to use in order to teach the subject in a friendly, approachable, and easy understand format. For the postnatal patients, we will also have the pap smear done. However, nowadays have the program. However, nowadays we have the program Rose from the University Malaya, which utilizes patients for self-screening for HPV, DNA testing for cervical cancer. The feedback from the women is that this is an easy, comfortable method and helps them overcome the embarrassment. We hope that we can offer this method to more Sarawak women. Now I would like to share my very personal story. Another story that I want to share is deeply personal. It's a story of what happened in my family. This makes me more eager to teach more women about this breast healthcare awareness. I had a niece who was a dear childhood friend as we grew up together in the Longhouse. In 2018, she told me that she suddenly felt alarmed while she was taking a bath in the Longhouse. So I told her she went to the as I have explained, so she went to the nearest clinic, which needed to be referred to Srikaya District Hospital. Then after that, referred to Sarawak General Hospital. The long diagnostic pathway took many months, and due to an overburdened healthcare system in the government sector in Sarawak, her treatment was delayed for a number of months. After her mastectomy, she was listed for chemotherapy. However, she sadly died 6 months later without receiving her first chemo treatment. I am grateful to the doctors and nurses who did their best to treat her, but we are in desperate need of the National Cancer Center in Sarawak. This is something that Datu Hafsah, YB Nurul Izzah, among others, have championing for many years, and I hope that this will become reality in the near future. At present, our patients have to travel 5 to 6 hours or more to access the healthcare facilities for diagnostic and treatment. They also have to spend hundreds of ringgit to travel by boat, four-wheel drive, and sometimes air from one end to another, to Sarawak to another. Sometimes patients in Lawas and Limbang have to travel to Queen Elizabeth Hospital, Kota Kinabalu, and Likas Women Hospital in Likas, Sabah. This has been even more problematic during the COVID-19 pandemic, when patients have had to get special permits to get the travel across the state borders. We need better cancer diagnostic and satellite cancer treatment units in the local district hospital throughout Sarawak, where patients can get their scans, surgery, and chemotherapy locally. Okay. We also need community palliative teams throughout Sarawak to deliver effective pain control and symptom control for patients with advanced cancer. To lift up their burden financially, the Peka B40 and My Salam programs are the initiative that have been provided some safety nets and support for patients with cancer. However, more needs to be done to support early cancer diagnosis in removing the barriers to care, especially in terms of transport, accommodation costs for patients that are traveling from rural areas in the district hospital for the diagnosis and the treatment. Patients in Sarawak and Sabah really need special allocation to enable them to access the healthcare services to enable early detection to save lives.
Okay, Cecilia, I think that was a fantastic sharing. I think what you've mentioned is almost describing all the 3 pillars of the WHO Breast Cancer Initiative: health promotion, timely diagnosis, and comprehensive management.
All right.
So maybe I have to stop you there because we have a very tight program. But we come back later on segment 3 when we discuss the issues.
All right.
Okay, maybe I'd like to invite now Crystal. She's a Together Against Cancer committee member and also a breast cancer survivor. We hear stories from Sarawak. Now we are hearing stories from Kuala Lumpur. The story of not just the B40, but also the M40 group. Crystal, would you like to share?
Hello, happy Sunday morning. My name is Krista. I'm honored to be here to share with you my treatment journey. Also, I would like to take this opportunity to welcome YB Nurul Izzah. Thank you, YB, for joining us today. I was diagnosed with breast cancer in 2013. I completed all the treatment, operation, chemotherapy, radiotherapy, and also targeted therapy. Why I need targeted therapy? Because I'm ER positive and also HER2 positive. So for ER positive, I consumed tamoxifen, later changed to Femara, and now I'm on aromacin. And on HER2 positive, this is the interesting part. Many people don't understand. They only know it's expensive, how expensive it is, how is the treatments going about, unless you are a HER2 patient, okay? Now you look at the chart. Don't get frightened with the figures there, all right? Because I was lucky that I have insurance policy to help me to pay for some medical fees, all right? So you look at the first round. First round, August 13, July 14. First round of treatment, I considered that as curable. I was cured after that. I have 17 times of Herceptin together with other types of treatment. And the figure I put up there is only the cost of Herceptin, together with the package that they give us, buy X free Y. So each treatment comes to about 5,005 just on Herceptin, and I have to do that every 3 weeks. So I have insurance to cover for me on that, and I also has purchased critical illness policy before, which they pay me as a lump sum. So I can utilize that as part of my treatment payment. All right. And then I was happy, you know, cancer-free, happy for 3 years, dancing with the Candy Girls every Saturday at Center Point. Then come to a day, I have a recurrence. We discover a growth on my spine, C2, in late 2017. Now, what does recurrence mean? Recurrent means the treatment has to be continuous. And the purpose is to prolong life. Am I so lucky that I'm HER2 positive? I have to continue with my Herceptin for the rest of my life. So I get back very fast. I get back to Herceptin and I spend another huge amount of money just to pay for the Herceptin. This amount here does not include doctor's consultation, other kinds of cancer treatment, and then the PET scan and whatever. Now, many of you may ask me, why do I choose a private hospital? Reason number one, the cost of Herceptin is the same whether you do it in a private hospital or in a public hospital. Reason number 2, as I mentioned earlier, I have insurance policy to help me. Whereas if you go to a public hospital, they don't help you in your insurance claim. You pay your bill, you bring to their reports department, you wait for the reports department to approve your bill, and then you bring the bill to the insurance income department and then claim your bills. So it takes a long process. And don't forget, my treatment is every 3 weekly. So I cannot wait, you see. So I decided to go over there. But of course, at a private hospital, I pay more on doctor's consultation, a lot more on radiotherapy, and also other kinds of visit. If you look at the last column, other treatments, these are drugs which I need to use related to my breast cancer treatment. And insurance definitely is not enough, because those days the policy is not like now, that like what we have, unlimited or 1 million policy. We normally buy about 100K or 200K. That is the average. So you look at it, not enough to cover. I have to buy aromacin, denosumab for my bone growth on my own, and then blood test to save some money. I do my blood test at the nearby clinic. And then sometimes we have complication occur during our treatment. For example, I'm facing thyroid problem. So this part, I will bear the expenses on my own, see? And then after 1 year, everyone was very happy because the biosimilar Herceptin is released in the market, and I switched to that, and instantly my cost of treatment has dropped by 35%. Now, I would like to mention here, if you use the biosimilar Herceptin, you only save 35%, not 50%. The reason is this biosimilar does not have the package called Buy X Free Y. All right, so I was happy for 1 year, and then I'm able, I feel slightly better. I'm able to buy other drugs on my own. Okay, until October last year, we discovered another growth on my C12, on my T12. Okay, that means Herceptin is no longer working well in my body. So the doctor has to upgrade me to line 2 treatment. So from that day, I changed from Herceptin to TDM1. Now, this is a newer medicine. This is a better medicine. This medicine is more effective. And of course, the price is definitely higher. Now, after 1 year of treatment, you can see the total cost. The cost on TDM1 only is already more than 150K. Now, I have a big headache. How to look for so much money for me to use every year? All right, so who can help us? Who shall we look up to? Of course, we look up to our government. All right, let's move to the 3rd slide. Okay, why we need to bring this up to our government? Look at the income tax relief. Okay, the income tax relief part. This figure has been there for a long, long time. That is the ceiling that you can get your relief for your EPF contribution, your insurance policy that you purchase, or any medical expenses on serious diseases. And when I added up the total, it's only 16K. It's very low. Are these figures really relieving us? To what extent? So we have to bring this up to the Ministry of Finance. Please, 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 by all means, look at this figure. Can you find a way to increase the ceiling? For example, life insurance, can you increase it to 5,000 per year? Medical insurance, can you please increase it to 3,000 per year? Medical expenses, can you please increase it to 10,000 per year? At least it makes sense. And point number 2, partnership. The first one, we leave it for the expert to do because that is very tough. I would like to suggest the second one. Pharmaceutical company and patient partnership. Okay, what do I mean by that? When I look back into my record, I have been using this Herceptin and TDM1 for more than 4 years. More than 4 years means I don't know how many times, every 3 weeks. Okay. Now, the pharmaceutical company should feel proud of themselves. Their research was successful. They are able to produce the medication that can help us to prolong our life. They are saving life. We buy the medicine from them, we use it, we save our life. This is a very good situation. Everybody is happy with it. But if you look at the price, how many of us can afford to pay this price without any insurance claims? It's no way, no way. I tell you, no way. It's very, very high. So I'm suggesting to this pharmaceutical company, please look into your customer list. Customers, okay, I'm a patient, but I'm also their customer, all right? Look at your customer list. I am a long-time customer, and forever I will be using your drug. Are you able to come up with a better system that can support me so that I can continuously using your drug at an affordable price that I can pay, not at this price? So I would like to suggest something like, if you have a customer for more than 3 years, maybe you should give better benefit to her. A customer or a patient which has been continuously, successfully with your drug for 5 years, give an even better discount to her. And then you may consider a patient who has been using it for 8 years. Now imagine 8 years. 8 years is a long time. We should give a big clap to this patient, and then maybe the pharmaceutical company maybe can give something like at a very minimum charge to this special case who has been surviving for 8 years. 8 years is a very, very long time for an advanced breast cancer patient. How many can hit 8 years? I can tell you the figure is very, very low, less than 20% or even less than 10%. I am a very good example of M40. M40 population or M40 patients do not get a lot of financial aids here and there. At the moment, there's only one. For new cases, breast cancer, My Salam will give you 4,000. If you are in the B40 group, My Salam will give you 8,000. So the N40, we are like in between, rich, not so rich. Can afford, sometimes cannot afford. To leave or to choose to give up, we don't know what to do, because eventually after treatment, we will face this big problem. No more money left. When there's no more money left, to give up or not, I don't think we will give up. So most probably the family will end up going out to take a loan, financial loan, bank loan, or whatever loan. And who to pay back the loan when the patient is no longer around? That comes to point number 4, insurance after cancer. I discover there are a few insurance companies in Malaysia. At certain times of the year, they may release some new life policy which do not require the person or the buyer to go for a medical checkup. So these will come in handy later on to help the family members to pay up the debt. That is my way of thinking, and that is my way of planning. Whether it suits another person or not, I do not know. I'm only sharing my experience. And why I say EPF not enough. M40 populations are the population that owns at least a house, they have cars, the children are well educated. So what happened to me is, when I look into my EPF balance, I have already utilized my accounts too before I was retired. You see, I use up my account too to pay for house loan. I use up my accounts too to pay for children's education. Now, one portion is already used up. That's why my EPF is, the figure is not big. and then employment insurance. B40 group are the ones who work for big company. Normally, this big company, they have proper insurance coverage for their staff. So when he or she is working, sometimes they even cover the spouse, okay? When it's working, no problem. Everything covered by the insurance. So these people, they forget to buy insurance on their own. They never buy medical card for himself or herself. They don't buy critical illness for themselves. You see? So the minute when they are retired, age 60, they left the company, their life is not protected by any of the insurance company. And everything they have to pay through their savings, their EPF or whatever they have. So this is a very sad case. We have to bring the alertness to the public that insurance, I'm not insurance agent, I'm not selling anything, okay? But insurance is important because through my experience, without this insurance, I won't be able to sit here and talk to you happily like what I am today, okay?
Thank you so much. Yeah,
I think
you have been really wonderful trying to help people understand more about what they should do to help themselves. So I think we will bring you back later in segment 3. And thank you so much for that sharing.
Thank you.
Yeah, thanks, Crystal. We now have Deborah Henry. Maybe you want to introduce yourself, but we all know you as the ex-Miss Malaysia, former Miss Malaysia. Thank you so much for being here, yeah?
Thank you, Aisha. Thank you so much. And I'm very honored to be invited to speak here, to share what I know working with the refugee community. And I think Cecilia and Crystal have said a lot. So I'll try just to focus mainly on the refugee and sort of more marginalized communities. And just a little bit of background for those who don't know. So I co-founded a nonprofit that primarily works with the refugee community in Malaysia. And we've been doing work for over a decade. And we essentially, when it comes to refugees, most nonprofits will not just look after specific areas such as education, but we tend to tap into healthcare, livelihoods, a lot of the community's needs from the time they're kids all the way to adults. So we sort of get our, I guess we sort of get involved in every aspect of their lives while they are here in Malaysia. So I think quickly it's important to set the foundation for why refugee women specifically perhaps don't even think about getting screening and are rather afraid or reluctant and don't have the means to access these services. So like most vulnerable communities, they live month to month. Their focus and the stress, if I were to use that word, is always on, can I earn enough money this month to cover my costs? The added challenge for refugees in Malaysia is that they are not able to work legally. So this is one massive red flag that prevents them from having, access to the economy, to work, to earn an income, to be able to make independent decisions over their finances. And also their rights to healthcare and education are also limited. So refugees in Malaysia are essentially urban refugees. They live amongst society. They do not live in camps. And even though they live, in the same apartment blocks as Malaysians and others, they are still very much siloed, isolated in the sense of their access to all these different services I just mentioned, but also isolated in terms of their access to knowledge. When you don't get to fully integrate with society on all different levels, be it education, in the workplace, socially, because of various barriers such as language barrier, your legality, you don't have access to that natural amount of knowledge as well. So they come to Malaysia with whatever they already know. And then because you're just living alone in your apartment and not encountering people, you're not getting access to a lot of the information that perhaps others would be getting access to. And of course, like I said earlier, their engagement with wider society is very much limited as well. And it is changing, though, to point out between, say, the older refugee generation and then, of course, the youth and children, right, who are growing up in Malaysia under slightly different circumstances. And perhaps through their schools and other touch points, they are sort of more involved, I guess, and have better access to knowledge and what's going on. So recognizing the struggles refugees face on a weekly basis is very important. Like I said earlier, earning enough money, especially now in a, I would say, post-COVID time or a current COVID time. You know, it's been extremely difficult for refugees, for stateless, for foreign workers to earn a living. To simply put food on the table is already challenging. And so the focus is simply not going to be on anything that is too far in the future. Unless it's super urgent and critical, they're not going to be thinking about it. So when it comes to even doing breast checks, it's as easy as you can do it in your shower. It doesn't take more than a couple of minutes. It's just not something that perhaps is top of mind.
Yes,
and in fact,
they have a problem. It's also difficult for them to seek medical.
Exactly. And so any check, any health check actually is not prioritized unless the pain or the concern is so great it becomes unbearable, and then they go see a doctor. So we see this often not just with breast cancer, but with all forms of illness, TB, diabetes. Unless they really cannot bear it, then they reach out to us and are desperate a lot of the times. So just quickly, overcoming stigmas and taboos. I think my fellow speaker mentioned this earlier. Many refugees come from very conservative cultures. They come to Malaysia with a lot of these pre-existing thoughts on how things are, and they could be right, they could be wrong. But especially when it comes to one's private areas, these are considered taboo. So, you know, questions we ask is, do mothers check themselves? Do they know that they can actually do that in the shower? Do they talk to their daughters? Because if a mother's not doing it for herself, the chances are she's not going to pass it to her children. How do we ensure women stay protected when it comes to their body, and that it's their right to get checked and have the independence to make decisions for themselves? So another thing we find is, firstly, it's having these conversations with the community itself, but also for some refugee women who do actually have the knowledge and they take an initiative to go and get checked and to make this and want to do things to protect themselves, sometimes they're met by medical professionals that don't support that decision. You know, you need your husband's approval. You need, because they're unsure the moment, you need your husband's approval or something like that, they tend to get afraid and then they step back. So that's one main barrier that needs to be overcome.
Secondly, Deborah, I'm so sorry to cut through your speech, but what we need to discuss is maybe later how we can do something about this. And Yolanda will be going to segment 2 to discuss this. And maybe if you are able to stay with us till the end, we'll be talking to Dr. Siti Noraida, who is really involved in how refugees can seek for medical help. Thank you so much.
Actually, Prof. Aisha, I think because Deborah might need to go a bit early, do you think maybe she could finish off, and then could we actually get maybe Dr. Aida to speak now after this, maybe as part of the conversation?
I suppose we could have to ensure that we will finish it on time. So of course,
I think we just move it forward. Yeah. So please, Deborah, would you like to just finish?
Thank you. All right.
Okay, sorry about that. Thank you. So just quickly, as I was saying, overcoming stigmas and taboos, that's a very important part. And I think a lot of the players on the ground have started doing things, but that's an ongoing something that needs to happen. So knowledge sharing is extremely critical, but the challenge, I guess, is how it's delivered. So NGOs like Fuji, like my NGO, as well as other community-based organizations, play a very important role in reaching out to the community and also being able to have the right materials and facilitators. This will make things a lot easier, because then you have the right kind of information being disseminated to the community. So another question we'd ask is, what does access to healthcare look like for refugees? It is definitely difficult, generally speaking, to access healthcare services in terms of limitations to which hospitals and clinics are offering services, because we know that not all government hospitals offer services and some give discounts to refugees. So fees and costs are also very expensive. So that seems to be a huge barrier why a refugee will not even think about going unless the situation is critical. Is the community aware of where to go for specific services? That this hospital over there actually does great breast cancer treatment. Does the community know? And then also, following that, are there forms of financial assistance that the community has access to? Because as mentioned earlier, things can get very expensive. So how do we communicate what actually is currently available to the marginalized community? How do we better communicate that to them and to the CBOs and nonprofits on the ground so they're able to then support the community in this way? And of course, important to note that most services are only offered to UNHCR card holders. So currently there is a backlog of refugees that have not received their blue cards yet. And of course, you have asylum seekers that have not been granted refugee status. So all of these people are still left in limbo. And so just in closing, I would say, using the current players on the ground, like existing community-based organizations, schools, nonprofits that are already in touch with the community, using them to disseminate this information and the workshops would be a great, I think, next step. And also taking the example from what's been happening with the vaccine rollout. You know, we've seen a lot of collaboration between organizations and nonprofits to get everybody vaccinated. So it does show us that if there's a will, there's a way. It can be done. It just needs to be prioritized, I think. Thank you.
Okay, thanks, Deborah. Maybe just to speed over to Dr. Siti Aida, who is, are you there? Yeah, maybe you can introduce yourself and we can have a little bit of the refugee segment before Deborah leaves our forum this morning.
Okay, can you guys hear me? Okay, I apologize if there's sudden noise because I'm in a public area. So good morning and salam to everybody. And I just want to sincerely thank everybody to include the migrant population into this breast cancer inclusion today. I think Deborah has given quite a clear picture of the lives of refugees in Malaysia. On my part, I probably would like to say that the issues are the same, right? There's always insufficient healthcare resources. And then there's poor acceptance of migrant population, and then the burdens see them as the locals see them as burdens, and then there's of course the economic priorities when it comes to policymakers. So it's the same story over and over again. I run a small primary care facility for refugees, which is why I'm here. It's called Clinic Aman Muhajir. So we start off as a small clinic, but I find that right now, because the refugee issues it's not just a simple healthcare provision anymore. It's very insufficient to say it's just healthcare provision for them, because it's a whole, it doesn't address the whole systemic health problem for refugees. I mean, amongst me and my staff, there's a lot of frustrations because we constantly have to battle a system where the refugees are seen as burdens to society. But just to highlight two examples of breast cancer cases to illustrate my points. Number one is Madam HN. Okay, she's a 41-year-old lady who came to us with a left breast mass for 1 month. There's no associated pain, there's no skin changes. So we referred her to our surgeon. We have a surgical clinic we have multiple specialist clinics in the sessions in the clinic. So we referred to our surgeon, and then the surgeon referred to biopsy was done, and then it was turned out to be an invasive carcinoma. She was referred to Putrajaya for a surgery, and then sent to HKL for chemo. And then after completing the chemo, she went back to HPJ for surgery. And now she's on follow-up and continuing treatment. The second case is 43-year-old lady. She has history of breast cancer on tamoxifen prior to coming to Malaysia. So these are all refugees. And she was actually referred to us for assistance with MRI. So because what happened is she developed some kind of weakness over her right upper limb. And she went to a private hospital who told her that she needs an MRI and then surgery, which is estimated about 15 to 20,000 to rule out a brachial plexus injury, right? So not being able to afford that, she went to a public hospital and she was given an appointment for 4 months. That's when she came to us for help. So noting her history, we couldn't not help her. So we did an urgent MRI within the same week, and she was found to have multiple right supraclavicular metastatic lymph nodes, with, of course, right brachial plexus injury. So she was referred for further treatment and currently still under treatment. So what I'm trying to say here is that intervention is sorely needed to ensure that the treatment is not delayed and it's recognized and pursued till the solution is achieved. So some of the issues we have to address, of course, is funding. I mean, it's a constant grouse for NGOs. I'm sure Deborah can concur with me. We constantly need to find money. We constantly need to make sure we have funds so that, you know, we don't have to choose who you want to help and who you cannot help, right? I mean, my friends recognize me as a professional beggar. I've accepted that.
Maybe you can also inform everyone about the safety net. Is there a safety net hospital that they can go to? Because for the citizens, we Malaysians are so very lucky. If you have a problem, you have no money, you go to a Ministry of Health hospital, that's a safety net. Yeah.
So actually, to be honest, there isn't a safety net. We have established some kind of we have established a kind of a CSR program with Beacon Hospital, which everybody is like, they have golden hearts there. But to be honest, only the ones who come to us, we assist them with MRI and then surgery. And as far as surgery is concerned, we still refer to government hospitals because we're very thankful with the 50% discount that they do get. But what is important here is the networking. So if a surgeon was to refer to a surgeon, there'd be a lot of time saved.
I can also add on, you know, if non-citizens use public hospitals, they have to pay the cost of the hospitalization. There's no subsidy, so it's actually double of what a Malaysian will pay.
Actually, they have 50% discount. Those who are documented,
refugees,
yes,
non-documented.
The nightmare is when they're undocumented.
Like if you're a factory worker, you'll be paying double. You're not a
factory worker, meaning refugees or not?
A non-citizen.
Okay, so non-citizen, definitely they will go based on a non-citizen price.
Yeah.
But when you're talking about refugees, we have documented and undocumented. The ones who are documented, they do get a 50% discount. Those who are not documented, they have to pay a price that is almost like a private hospital. So part of what we do is attempt to get them their status under UNHCR. So that's one of the things that we have to do. So if that is available, if they are documented, then they can go to the public hospital. But the problem is that the time that is required for them to be able to be seen, and sometimes you refer them, they don't go because they don't have enough money for registration, they don't have money for transportation, there's no one to take care of the kids, and then so it's actually and they're also worried about being detained, right? I mean, that's one of their worries. So you cannot just refer them and expect them to go for treatment. So
as mentioned in the beginning, this is really the titik permulaan. We're thankful that YB is here, and we hope to bring these conversations further, you know, about refugees particularly, and also the non-citizens particularly, because there's no safety net for them. And for doctors also, we're all having a headache how to pay their bills, how to get them to have treatments. So let's move on, because I really have to apologize to both Deborah and Dr. Siti Aida. Both of you have been really wonderful in contributing, but we really need to go on to the next segment. And I'll pass this to Yolanda to chair the next session. Thank you so much.
Yes.
Thank you so much both.
Yeah, thank you so much, ladies. So kita akan membuat sesi yang kedua dalam dua bahasa. Boleh kan, Prof?
Boleh.
So selamat pagi semua, terutamanya kepada kawan-kawan kita yang mengikuti siaran ini dari Sarawak. Apa khabar kita orang? Nama berita? Hope you're all doing well today, and thank you so much for joining us from Sarawak. And well done to all our community healthcare champions and Know Your Lemons educators in Sarawak. It's a very, very significant day to actually see this whole program grow. And I hope that we'll be able to actually talk more about Sarawak in future programs. So dalam sesi ini kita akan sama-sama membincangkan cara-cara untuk memperbaiki akses kepada maklumat yang tepat, ujian saringan kanser payudara, dan juga akses kepada rawatan yang berkesan. Sekarang saya ingin mengajar Associate Professor Dr. Hairin Abdul Hadi pakar perubatan keluarga di PPUM untuk membincangkan isu pengetahuan kesihatan payudara, iaitu Patient Breast Health Literacy dan juga penjagaan kesihatan community primary care. So over to you, Dr. Harin.
Okay, Assalamualaikum and good morning to Prof. Aisyah, Dr. Yolanda. Thank you for this opportunity, and to Yang Berhormat Pak Nurul Izzah for being here this morning, and to everybody who is spending some time with us this morning. Let me, before I proceed with let me share with you my slide. Can you see my slide? Yes? Okay. So before I proceed, I would like to give a quick overview what primary care physicians do. Basically, I think everybody knows that we are the the frontliners in the community. So we are the doctors in the community. We are called by the name primary care or family physician and also general practice. So the community doctors are basically either in clinic kesihatan or health care centers, or they can be private in clinic GP clinics as well. So the type of patients that we see are from all range of ages, young to old, men, women, and those people who are sick and those people who are well, but they are concerned of their illness. So so in terms of breast health literacy, what is it and how do we improve it? Because I think from the previous speakers, I mean, it's very enlightening and very informative to see, what is happening outside in the community. So perhaps those doctors in the hospital might not or maybe have heard a little about it. So in terms of breast health literacy, I think it's very important for us to see, what are the challenges that the primary care physicians face. How do we improve on the knowledge of breast health, and how do we improve in terms of knowing the signs and symptoms as well as how to navigate. So we know from previous studies that some patients have come late for diagnosis. Either they don't know, the bodily changes. For example, like in breast, they can have skin changes, discoloration, nipple discharge or lumps, and they are not aware of it because they don't know how to look for changes in their breasts, or they are not aware that things can happen to them, because as Dr. Aida has has enlightened us with the two cases. They are quite young patients, in the 40s. And these are the patients who probably do not come because they think that they are well and they are young, so nothing much can happen to them. Only, the old people are going to be sick. And the access to healthcare, especially, like Ms. Deborah has shared to us, I mean, those are refugees. So they are limited in accessibility to healthcare, but in our own community who has access to facilities, they do not come forward. So these are the health literacy that we need to be aware of. And as I've mentioned before, the group of patients that we see in primary care ranges from all ages of groups. So, they should not, the type of patients that we see can be a lot of, with a lot of sickness. So we have to be opportunistic in our approach when we see patients. So when patient comes for example, blood pressure monitoring, we have to be opportunistic in the sense that we have to make them aware that there are some things that they need to do at home. For example, breast examination, when to do it and what to look for. So this is very important for the patients to of their bodily changes that can happen. And some of the challenges that we also face in the primary care setting is that why patient come in late for diagnosis, because when we say that there are some other changes in the breast, they might actually go to other doctors, because the health system in our country is such that we do not have like what UK has, there is a direct communication between the general practice and the hospital. So, and there is open access to GPs, to all other, klinik kesihatan, so they can doctor shop. They are not happy with this one doctor because, they make a particular diagnosis today, so they go to another doctor for a particular diagnosis. So they eventually, when they end up in the hospital, it's already quite late in the stage of the disease. And there are some myths and stigmas, as mentioned from the previous speakers, that this is probably because of sihir, black magic, or because of stigma, because breast is considered as a sexual object. So think about it to other people, because then, because of the taboo of it being a sexual organ. So there are some limited facilities. They think that there are some limited facilities because of financial issues, that they think that nothing can be done about it because they already diagnosed it. Treatment of cancer is very expensive, so they don't come forward. And the communication, as I mentioned, between primary care doctors and the specialists based in the hospital is quite limited because we do not have a direct communication. So as a generalist, we do need some support from the subspecialists for further opinion, assessment, and also management of patients. So that comes how we're going to reduce the gap of this literacy, how do we improve literacy is by having this REBUNG project. So REBUNG means melentuh bulu biala dari rebungnya. So we are trying to empower the community leaders in the community to teach their individuals in the community to reduce the barriers in terms of of early diagnosis in cancer. So there are many sub-programs of REBUNG. So mainly it's how we empower navigate the people, how to get to come to a diagnosis, and also how do we, I think Ms. Deborah mentioned how we deliver and how do we communicate with the community. So this is what REBUNG project is. So this is also to emphasize that wait for any signs or symptoms. This is have any signs or symptoms, before they come forward. So the earlier diagnosis, the better. So the earlier stage, and also, our tagline is, what was that tagline? Forgot our tagline now. Badan kita lah jaga. Badan kita lah jaga. So meaning that, you cannot wait for somebody else to make you aware of your bodily changes. And in fact, these community leaders will have, so this is where REBUNG is. So we are going to link the community to the hospital, to NGOs, and also to to the stakeholders of the community. So REBUNG is divided in terms of community, is divided into two groups, whereby leaders. And in terms of community leaders, we train them how through videos on how to on 4 main cancers, basically breast by using Know Your Lemons, and colon cancer, lung cancer, as well as cervical cancer. So we teach them what they need to be aware of, in terms of their bodily changes, as I mentioned, lumps or discharges and all that, and what to do when they have this, and how frequent the screening is going to be like, and where if they were where to go, they can ask the community leaders, what kind of support do I need, and all that. But of course, the community leaders are not doctors, so they need to navigate this community, that they can actually go to ask further opinion from the doctors in klinik kesihatan and to get further assessed in these facilities. And the doctors, so when they go to the clinic, they also need to know that they can. So they need to be aware of what the doctors will do. For example, like breast, the breast will be examined further, and they may be referred to the hospital for further medical checkup by the specialist in terms of mammogram, because not all health clinics machine, or for diagnostic center they might have, and so they need to know how this mammogram is going to be like, and if biopsy is going to be taken, so they need to know a little bit of how the procedure is going to be like, so as to prepare them what is going to be done for a proper diagnosis. So in terms of that is of the diagnosis, but we also navigate them of where they can get help. And unfortunately, with the national state programs in terms of financial aid, or they might be, if I'm not aware of, but at least in our B40, there are aids available that has been organized by the state, like state program in Peka, Maisalam, for screening purposes as well. So that's basically what REBUNG is, and some challenges that primary care will face. But I think it's good that we have this, so that we know we can empower the community to come forward to the primary care doctors, and primary care doctors can have training as to where and when we need to refer to the hospital, and hence in future we can have a better communication in terms of patient management, and hopefully there will be no fall in follow-up from the hospital to our center in the community.
Terima kasih, Dr.
That's my
Haireen.
last slide, and I pass you back to Dr. Yolanda.
Yes, thank you so much. Great sharing, and we look forward to seeing REBUNG grow and be implemented. So sekarang kita akan mendengar pula daripada Prof. Aisyah yang akan membincang akses kepada ujian diagnostik dan rawatan untuk kanser payudara. Prof. Aisyah, boleh kita stick to 5 minit sebab we're a little bit behind time. Thank you.
Thank you, Dr. Yolanda. I have some slides to share, but I thought I will basically share about some of the things that we are doing right now. So one of the main things that we are embarking on is called the City Cancer Challenge. And this is based in the Greater Petaling area, which involves all the districts in Selangor, as well as the Wilayah Persekutuan Putrajaya, as well as KL. So the Greater Petaling Jaya City Cancer Challenge is really a movement of a group of people, multi-sectoral group of people, to improve access to equitable cancer care. This is a global movement of cities where we are the 9th city to join this whole movement. We have a city manager, and you can actually email him if you're interested to be part of this movement. What we do is, maybe the next slide, Shahira. So we are the 9th city. So you can see in all continents, there are many cities. So we are the second one in Asia. Next one. Okay, so we launched this in June, and an MOU was signed in May between the Selangor the city councils, PJ, Shah Alam, and Subang Jaya, and as well as National Cancer Society, with the support of the Selangor Health Exco, as well as the DG of the Ministry of Health. So this is a very strong movement. Can we move to the next slide? I'd like to show you, this is the membership of the City Executive Committee that will steer the whole project that will take about 2 years. So we are now in the first phase, but this is the steering group. We have 19 members. You can see good representation from the political side, from the Selangor State Government. We also have from the city councils, as well as Ministry of Health. So you can see in here, we have the the heads of the surgical and oncology divisions of Ministry of Health that is actually in the committee. And we have even Liam, Life Insurance Association Malaysia, as well as Dr. Azlan from SOCSO. So this whole group will be convening to help steer the City Cancer Challenge. So let's go to the next slide. Is that the last one? Okay, so essentially this one, I think you go back to the last slide. So what we have is a 2-year project. The first one is a situational analysis, and that will happen in 33 hospitals in the area of Greater Petaling, And this is to identify the gaps of what we have in terms of quality cancer care. So we're not looking only on treatments, we're also looking at diagnostics, we're also looking at patient access. So there will be 200 people with cancer that will answer our questionnaire with regards to their access to care. So I invite, maybe we should send some questions to the refugee NGOs also, so that we can also identify some of the gaps that they have. And after the situational analysis, there will be analysis of all the questionnaire and discussions among the working groups and the technical committees. So we have 4 technical committees, which is the quality management committee, we have the diagnostic committee, we have the management committee and the patient access committee. And within this, we have something like close to 30 working groups that will involve not just healthcare professionals of different types. That means you have surgeons, oncologists, social workers, psychologists to discuss. And finally, we will come up with 8 to 10 action plans that will be sustained through a sustainability financing innovation workshops and through global partnership. That means we have partnerships with even the World Bank through the City Cancer Foundation, which is based in Geneva. So this movement of cities is trying to garner non-health sectors also to be involved in health, and together we can come up with sustainable solutions. So we can see that probably in Malaysia, the action plans could just be like improving access to community hospice services. We hear all the stories about advanced disease, and I think the right of people to a quality, I mean, I wouldn't say death, right? But some, quality of life of people living with cancer, even in the late stages, would be important. And also we think that the next one would be something related to financing healthcare. Maybe there should be public-private partnerships. So this could be another action plan. But we will wait until we get all the evidence together, and hence we bring on to the workshops where we can actually come up with those sustainable solutions.
Yeah, okay. Terima kasih Prof. Aisha. So I think now this leads nicely on to the next speaker. Sekarang saya mempersilakan Saudari Yok Ling, Peguam dan juga pakar advokasi di Third World Network, untuk memberikan pandangan tentang kos rawatan kanser dan cara-cara untuk memperluaskan akses yang sama rata dan adil, affordable access kepada rawatan kanser yang berkesan. Saudari Yok Ling, over to you.
Terima kasih, Yolanda. Sorry, it's going to be in English to save time. Jadi, I think listening to, especially I think Crystal's story, how do you manage the whole cost of treatment? And I think within Together Against Cancer, one of the big issues we've been very focusing on is how do we get access to more products in the market. With more products, we will have more competition, the price will go down. That's a basic fact. So one of the things that we have identified in here, I want to focus in the next few minutes, what is the way we want to go forward to overcome, and I'm talking here about high and unaffordable prices, because Malaysia has a dual system. So our public tax-based system is also funding, right? So when we have affordable products, like we see in HIV/AIDS, we see in hepatitis C, when we have that affordability of the medicines and the diagnostics, we can actually give free treatment for all. Right, so this is something that's very important, and the cost is one factor why in cancer treatment we are actually not delivering the right to all. I mean, we're not even talking about the non-citizens. Even citizens don't get it. So if we want universal healthcare for all in Malaysia, regardless of citizenship, we have to tackle the issue of affordability for the private sector, and I mean for consumers and also for the public sector. So one of the major areas really why we are having no competition and prices can be set at the will of the manufacturer or the importer is because of intellectual property monopolies. Now, I only highlight here two. One is patent. I think the vaccine debate has given us all in the public a lot of awareness. But those of us in the cancer and access to medicines fight have known for a long time that if we have very loose standards about when we give this 20-year minimum for a patent, we actually end up having monopoly in the market. Now, one medicine is many patents. It's not one medicine, one patent. You can have many, many patents around a medicine, and they can be actually applied for at different times. So in reality, the monopoly in the market where you cannot, without the permission of the patent holder, bring in generic products or even for a local company to manufacture, that is in effect more than 20 years because of the multiple patents, right? So the other one, of course, is trade secrets, because even if there is no patent, or you can work around something to do with the patent, to make the product, this is about manufacturing. There's a lot of know-how and technology information that, again, if it is not shared, you cannot make it. Now, sometimes you may actually know how to make it in a local company, but because it is asserted as a trade secret, you are blocked by this legal barrier. And there is no time limit. There's no 20-year minimum. Trade secrets are forever, all right? But what people normally call the recipe for making a drug. Now, Malaysia's Patents Act 1983 is going to be amended. There's been a lot of discussions for many years, and there's been going to and fro, right? Now, all these issues around intellectual property is the responsibility of the Ministry of Domestic Trade and Consumer Affairs. And this is very important. And within that is the agency called the Intellectual Property Corporation of Malaysia, my IPO. They examine all the applications for patents, etc. But policy is set by the ministry. So this is a very important area of action for us. Now, this Patents Act amendment, there have been some consultations with the public in the last couple of years. And we are very worried that some of the proposals from my IPO, which is leading this amendment process, is moving in the other direction. It's going to create more monopolies and longer monopolies. So we have to make it more public health oriented. And this is where we need to work with the public awareness building and also with the members of parliament and with the ministry before they go to parliament. The other aspect before a medicine can get into the market is actually registration by the Ministry of Health, the National Pharmaceutical Registration Authority, or NPRA. So this is where we have registration to ensure that there is safety, quality, and efficacy in the pharmaceutical products and vaccines, etc. Now, of course, for cancer and most treatments now, we are moving from chemical-based medicines, which are smaller molecules, and increasingly we are moving towards what we call biological drugs. Yeah, and biological drugs are where you have bigger molecules. You have a slightly more complex way of making, but that's where we are heading. And cancer drugs mostly are falling into biological drugs category. Now, if you have a chemical-based medicine with small molecules, and many of us are using that for all kinds of treatment as also complementary medicines for cancer, then what we can have is what we call generic when you bring in that is actually done by the non-patent holder. For the biological medicines, what we have is called biosimilar. Now, if we have these generics or biosimilars in the market, then the prices will go down. I think Crystal mentioned, yeah, for Herceptin, which is the brand, the originator drug, the minute in 2019, one of our local companies, because the patent expired towards the end of 2019, and a local company started the process 2 years before to apply for registration, because registration can take up to 2 years. And it's not cheap. You have to buy the originator, run some tests, compare your biosimilar or generic. And so people think that generics or biosimilars are just copying the originator. No, you have to go through this process of registration. And for biological drugs and biosimilars, it can cost up to a few million ringgit because you need to buy the originator and compare to do some tests. Yeah. So in 2019, when trastuzumab, which is the generic name of the Herceptin, was introduced to the market, overnight, the originator, the patent holder, Roche, dropped the price by 52%. Just overnight, literally from after midnight when the patent ended, because there was a second product in the market for competition. Now, for the last, we saw the Ministry of Health had procured a 2-year contract before 2019, before the drop in price. It was about 43 million ringgit for 2 years. Yeah, a limited volume. With the drop, the next contract was 21 million. Just because the patent ended. Now the question is, why can't the bigger discount be given beforehand, right, by the company? Crystal talked about how for patients who've been on treatment for a long time, can't the company give us better discounts? I'm afraid in the experience of many of us working on this, the big pharmaceutical companies are not very sympathetic. We see the vaccines, yeah, there's a major global shortage of vaccine because they won't give more licenses so that more people can make it, more companies can make it. So I think in terms of our private collaboration with private sector, we have to see which part of private sector and how to collaborate, yeah, because not all of them are going to be with us, but nevertheless, we should try. Now, the other area of possible action is our Malaysian Competition Commission. This is also under the Ministry of Domestic Trade and Affairs and Consumer Affairs. And the role of the Competition Commission is to implement a law that seeks, among other things, to prevent abuse of what we call dominant position in the market. So if you're the only supplier in the market, the only importer, the only manufacturer, and you could also be a generic and be the only one. If you abuse your position as the only supplier and you just set prices very unfairly and create a monopoly, there can be actions taken against you so that others can bring in the product. So this is something that we need to look at as possible areas of engagement. I will end very quickly. In the 12 Malaysia plan, recognizing that we are very dependent on importing everything in terms of medical devices and pharmaceuticals practically. Yeah, we have potential in this country to manufacture. We have very high standards in the MOH for quality and safety and efficacy. It's not easy to register a product in this country. We follow basically the EU standards. But we have a problem with intellectual property barriers if you talk to the local industry, right? So quickly, just to highlight, in the 12 Malaysia plan, these are quotes from the 12 Malaysia plan. Efforts will be undertaken to increase domestic investment in our local industry by commercializing R&D findings so that we have sustainable medicine supply in Malaysia. Cancer treatment is probably one of the worst affected, actually. So we have to think about how to do this. Relevant policies will be reviewed and roadmaps will be developed. This is where work like the City Cancer Movement and all those very concrete evidence-based recommendations can go into the policy discussion. And lastly, the rising cost of pharmaceutical products and medical equipment is of concern to consumers and to the government for the public health system, I would add. So the existing strategy, according to the 12 Malaysia plan, will be enhanced by expanding pooled procurement. Very important. Right now, university hospitals are buying on their own, MOH is buying their own, and private sector is buying their own. So can we do pooled procurement nationally? And also pooled procurement at the ASEAN level, which is a very interesting idea that's been talked about, but it's in our Malaysia plan, right? Now, in addition, a price control mechanism for medicines will be introduced by the Ministry of Health in collaboration with the Ministry of Domestic Trade to produce consumers from unfair pricing. So these are potential next 5 years commitment of the government in the 12 Malaysia plan. Let's use this, engage with the different ministries. I haven't got the whole list because talking about refugees and migrant workers, we need to deal with the Ministry of Home Affairs and Immigration Department because they keep arresting people when the Ministry of Health says let's not arrest them, right? So we have this problem. So, but we need to think about how, as activists in the public health sector, we need to actually work with our parliamentarians, get the laws right, and work with the government to get the policies right and the implementation right. Thank you.
No, thank you so much. That's a brilliant overview. This feels like a whistle-stop speed dating for cancer policy. But yeah, fantastic. So I think with that, we'll now go into session 3, and it's with great pleasure that we welcome YB Nurul Izzah, a policymaker, women's health advocate, and member of Parliament for Pematang Pauh. YB Nurul recently launched the Pematang Pauh Multidimensional Poverty Index Report 2021, together with Professor Fatima Kari from University Malaya, Professor of Economics and Director of the School of Poverty and Development at We will now hear YB Nurul share her insights on how we can address the urgent issue of healthcare poverty amongst women in Malaysia. Over to you, YB.
Assalamualaikum warahmatullahi wabarakatuh. Salam hormat semua. Thank you so much, Dr. Yolanda. We also had Prof. Irene and Prof. Aisha, of course, the expert Lin just now. I will actually prepare my speech in English, but I think what Yolanda started with, by the way, everyone should know she beat me in Bahasa Malaysia, super BM speaker, top scorer, so it's not a surprise. Hanya jadi saya rasa untuk the benefit, manfaat semua yang mendengar, kerana kita kena pastikan lebih ramai lagi daripada kempen Know Your Lemons, Together Against Cancer. Kalau ramai faham bahawa penjagaan diri penting, kita mampu menyelamatkan lebih ramai lagi nyawa, insya-Allah. Jadi, of course you know about the data, kita tahu ramai orang akan mendapat kanser. Kalau statistik di Malaysia ini, kanser adalah yang kedua mengakibatkan kematian awal atau berbanding dengan heart disease ataupun penyakit jantung. 1 daripada 7 individu kita anggarkan akan mendapat kanser sebelum mereka sampai umur 75 tahun. So ada program-program screening, dan saya fikir mahu tidak mahu statistik juga menunjukkan tak memadai, orang takut ataupun apa yang ada, masalah yang ada. Akhirnya untuk penyakit kanser payudara 48% selalunya peringkat atau fasa stage ketiga, kanser colorectal 73% stage keempat. Jadi kita kena merancang supaya belanjawan ke RMK 12 lebih memastikan rakyat kalis kejutan. Kejutan ni termasuklah kalau didiagnos sebagai pesakit kanser dan kalis cabaran masa depan termasuk pandemik. Jadi saya nak ceritalah memang bercakap tentang konteks wanita. Kita sebut multidimensi ni kenapa? Kerana kalau cakap pasal survivorship pun, satu, tadi Crystal Ng ada memberikan pembentangan yang sangat efektif iaitu dari segi kos kewangan. Tapi tak cukup dengan kos kewangan. Dahlah sakit dari segi dana kan yang kurang. Sakit juga fizikal, sakit juga kemo, sakit juga bila terpaksa menanggung daya tahan emosi. Jadi isu survivorship ini termasuklah co-survivors juga pelbagai dimensi dan ini masuk kepada kajian kami yang disebut oleh Yolanda tadi, indeks kemiskinan pelbagai dimensi. Kita boleh jadi miskin bukan hanya dari segi kewangan tetapi juga akses kepada khidmat kesihatan. So the Oxford Poverty and Human Development Initiative (OFI) dah lama bersama kolaborasi UNDP mengira bagaimana kadar kemiskinan rakyat di negara-negara membangun. Dan mereka datang dengan indeks MPI. Barulah kita nampak kesan dan bagaimana perkembangan rakyat menerusi tahun ke tahun. Dan untuk tahun 2021, mereka wujudkan indeks multidimensi kemiskinan seluruh dunia yang melihat kepada kesan COVID. Jadi di Permatang Pauh, itu yang kami mahu tangkap sebenarnya. Tangkap kesan COVID kepada pelbagai jenis kemiskinan yang dihadapi oleh rakyat. So we targeted on B40 because we felt that kalau cakap tentang T20, M40 dan sebagaimana disebut oleh Crystal, juga Cecilia, M40 sedih tau because they're squeezed in the middle. So this is not by any measure the fact that they're not important. Tidak, hanya kita dengan Profesor Fatimah kali kita bincang lama, sampel kita pada awalnya nak ambil kira juga refugees. Kita nak ambil juga golongan yang tidak punyai dokumentasi untuk kita melihat bagaimana kemiskinan dan penyisihan yang mereka hadapi. Malangnya kerana COVID, we had to make sure, I think the survey was conducted April to May 2021. Kita kena pastikan enumerator selamat. Saya guna pelajar di Permatang Pauh, Profesor Fatimah, ekonomis, mantan profesor di Universiti Malaya pun selamat. Jadi nak tak nak kita kena kecilkan survey dan jumlah sampel. Jadi kita tak sempat nak meneru-meramah keluarga-keluarga kerana sebagaimana Deborah sebut tadi, kadang-kadang untuk mereka yang tidak punya status kewarganegaraan, dia berpindah juga untuk selamat. Kadang-kadang tidak ada ketentuan kediaman itu tidak akan diceroboh oleh pihak berkuasa. Jadi ini menyukarkan kita untuk mengenal pasti mereka di mana. Okey, jadi dari segi keputusan ini menunjukkan Ketua Isi Rumah Wanita jauh lebih tersisih dan lebih-lebih lagi lah bila bercakap tentang dimensi kesihatan, mereka yang punya critical illnesses macam kanser. Saya ingat pertemuan saya dengan Profesor Wu Yinling. Beliau sebut kenapa beliau datang dengan projek ROSE, datang dengan cara untuk membuat ujian screening HPV DNA yang lebih mesra kepada wanita B40 kerana wanita B40 yang duduk di PPR selalu datang dengan kanser cervix peringkat ketiga dan 4. So it's gonna a matter of months before they pass away, leaving their children behind, and it's a very tragic predicament that they face. Jadi dalam masa COVID, lebih-lebih lagi mereka berisiko kerana mereka terpaksa mengambil kira kos untuk selepas mendapatkan vaksin, but the problem is the hospitals are affected. All the services for diagnostic purposes or for all the minor surgeries are affected, including non-COVID related patients because of the pandemic. Jadi akhirnya kerajaan sekarang dalam konteks belanjawan harus mengambil kira kesan pasca COVID kepada postpone appointments, delaying elective surgeries untuk menyerap jumlah pesakit COVID. Saya berbincang dengan pejabat kesihatan negeri Pulau Pinang I remember we were talking about harm reduction for the increase of drug users during COVID. Jadi mereka kata, finally we're talking about something other than COVID. So COVID is important, talking about booster shots and increasing vaccination. But, you can sense banyak doktor merasakan, alahai, banyak lagi pesakit lain juga yang terpaksa dikesampingkan akibat COVID. So this has to be taken into account in the way the budget is being dispensed, in the way that we plan and we plug in the needs for the Ministry of Health. Jadi saya rasa when you talk about the female multidimensional poverty and cancer care access, saya nak merujuk kepada laporan yang dibawa oleh kajian Mahmud A dan Al-Junaid SM pada tahun 2018. Dia kira jumlah kilometer yang terpaksa dilalui oleh pesakit yang bukan pesakit, they underwent mammograms, ujian saringan mammogram, dan dilihat ada yang terpaksa berjalan 8 km, ada juga yang berjalan 112 km. Bayangkan jumlahnya, RM7.60 untuk parking fee termasuklah petrol dengan RM78.40 just to go for screening, right? Jadi kalau ambil the highest expenditure, lebih kurang RM78.40 sebulan, dalam grup B1, grup median income antara RM1,929 sebulan, ia ambil 4% daripada gaji mereka. Ini tak termasuk dengan kos-kos lain, hanya untuk saringan. Dan ini membuktikan menerusi evidence-based research, the ASEAN Cost in Oncology 2012-2014 also found that seorang daripada 2 cancer survivor, 51% akan terjerumus dalam kemiskinan dalam tahun pertama bila lepas mereka mendapat diagnosis. 49% akan guna semua dia punya simpanan untuk dapatkan ubat-ubatan dan treatment rawatan, dan 39% tak boleh bayar pun untuk ubat-ubatan. Dan 35% kata mereka tak boleh dapat mempunyai dana yang mencukupi untuk medical consultation, dan 22% langsung tak boleh bayar sewa dan pinjaman lain. Akhirnya 19% terus dia cancel, dia tak mahu lagi go for treatment because of the economic hardship. So in total, because of cancer, 1 daripada 3 isi rumah 33% dalam survey sebelum COVID jatuh dalam PLI, iaitu poverty line income, paras pendapatan garis kemiskinan bagi tahun 2014. Ketika itu RM980 satu isi rumah. Tapi dalam belanjawan terkini, pemberian dana, kerana kita tahu COVID menjadikan semuanya worse off. Maksudnya data yang kita ada yang saya rujuk tadi akan jauh lebih teruk selepas COVID, tapi paras pendapatan garis kemiskinan dia tak guna pun yang telah dikenal pasti pada tahun 2019, iaitu RM2,208 seisi rumah. Ini menjadi intipati kenapa survey, kenapa measurement of poverty yang realistik itu wajib kerajaan lakukan dan wajib laksana dalam penurunan dana, kerana akhirnya if you use the flawed, the old poverty line income, macam mana orang yang layak yang sekarang jauh lebih teruk daripada dulu boleh survive, boleh teruskan hidup dengan sempurna, dengan berkualiti. Jadi kita agak kecewa kerana semasa pengumuman belanjawan, paras garis kemiskinan yang diguna pakai adalah bukan pun RM2,208, tapi dia guna PJK makanan yang lebih rendah daripada PJK keseluruhan tahun 2019. I say this because akhirnya yang merasa adalah rakyat yang disasar. Kerana itu walaupun dana yang diperlukan adalah tinggi, kuantum dan jumlahnya, tapi kita jangan ambil mudah kerana di seluruh dunia orang tak lihat pada hutang dah. Kerana hutang demi untuk menyelamatkan nyawa rakyat itu adalah sesuatu yang penting untuk melindungi dan membina pelampung keselamatan yang memadai. So late detection and delays, clearly, you guys know this, supportive care and, making sure that people have sufficient support to address the financial burdens. Jadi saya rasa tadi disebut tentang beberapa skim yang disenaraikan dengan baik oleh Crystal. Saya hanya nak katakan memang betul sangat-sangat kalau tengok simpanan EPF dengan bantuan SOKSO pun tidak memadai walaupun ada ya. Kita tengok contoh My Salam RM8,000 seorang hanya meliputi mereka dengan penyakit yang kronik dan kanser ini beberapa fasa. Jadi tentunya you're not covered lah if you're on stage 1. Sedangkan kalau stage 1 tu lah you need the utmost care to ensure that you have a longer survival rate. Jadi pada saya yang disebut tadi juga didukung oleh kajian Sabrina Nur tahun 2019 bila bercakap tentang kemoterapi dan akhirnya kerana ubat-ubatan di luar Kementerian Kesihatan khususnya in the Ministry's Essential Medicines list, some of the medication is outside government hospitals because they're not listed. So all these key things which Ling also showcased is very important because it affects people on the ground. Peka B40 scheme untuk mereka yang umur 50 tahun ke atas maksimalnya RM20,000 had untuk membeli medical devices, RM1,000 insentif untuk menyelesaikan the cycle of cancer dan bantuan transportation pengangkutan RM500 untuk secara maksimal untuk setiap penyakit bagi di Semenanjung, RM1,000 di Sabah dan juga Sarawak. Tapi akhirnya masih lagi terhad kepada pesakit dalam hospital kerajaan. Jadi ini juga tak termasuk it doesn't include my university PPUM, Pusat Perubatan Universiti Malaya dikategorikan sebagai teaching hospital. Jadi tak termasuk dalam kategori ini. Justru capaian masih terhad. So rekomendasi, again as you said, speed dating, saya ada beberapa cadangan tapi tentunya hari ini juga saya mendengar dan insyaAllah kita muatkan dalam pembentangan belanjawan menerusi jurucakap tertentu. Hanya we need a strong lobby. Why? Because kalaupun beberapa insentif diumum dalam belanjawan 2022, it's not sufficient because it has to plug in more gaps and dia kena ambil kira pelaburan yang sangat tinggi untuk mengatasi krisis pandemik yang bersifat sistemik dan harus dimasukkan ke dalam Kementerian Kesihatan dan Kementerian Wanita. So if you want to see change, this is the year to invest because macam cancer lah, there's a ticking, the clock is ticking. Sama juga dengan bagaimana kita merencana RMK12. If you don't invest now, of course the country will be bereft by many people yang tak boleh nak lompat ke atas. There's no springboard. Kerana kemiskinan itu daripada kajian kami juga menunjukkan dia tak cukup simpanan masa depan. Jadi macam mana dia nak belanja untuk hari ini? Kerana dia kena fikir nak belanja untuk hari ini pun tak cukup untuk menampung semua keperluan dan kalau ibu tu terkesan, anak-anak dalam isi rumah tersebut jauh lebih terkesan. So you're talking about intergenerational crisis. Especially more for those who are afflicted with cancer. So the first recommendation that I would suggest, for discussions purposes, untuk tentunya membuat ujian saringan awal di Parlimen hari Isnin. Soalan saya minta agar ujian HPV ini khusus untuk pelajar 13-14 tahun, pelajar perempuan yang telah they missed their turn during school closure. Jadi kita nak pastikan secara automatik mereka mendapat vaksinasi bagi HPV, Human Papilloma Virus, supaya tidak ada seorang pun dalam kohort yang tertinggal dalam 2 tahun sebelumnya, mereka mampu mendapatkan vaksinasi tersebut. And so we talk about, especially for most cancers, they are detected outside screening programs. Jadi kita kena perbaiki laluan untuk rawatan selepas kita memperbaiki juga program screening dan ujian saringan. Di Pulau Pinang kita antara jumlah yang tertinggi mendapat kanser payudara, kanser cervix dan antaranya adalah kerana screening is very high. Jadi kita kena, saya ingat saya pergi pasar malam, saya pergi tanya dekat setiap peniaga lelaki, saya kata, has your wife been, has she done her HPV testing? Jadi pada saya, sebahagian daripada usaha untuk memecahkan tembok tabu, supaya mereka tahu perkara ini, saringan ni is normal, right, for safety, nak jaga kesihatan kesemuanya dan boleh menyelamatkan nyawa. Kedua adalah pushing the limits of treatment and care. I think Yok Ling brought up a very crucial issue. We have to look at the impact of TPPA, the impact on our government's power untuk mengeluarkan disebut pelayanan wajib, compulsory licensing, because for those who have hepatitis C, sofosbuvir, untuk penyakit-penyakit kanser lain, you have to think and be at the edge of science. Dan pengalaman dengan Pfizer versus AstraZeneca juga patut mengajar kita lebih-lebih lagi dalam dunia penyakit kanser. Kita harus kurangkan dan turunkan harga bagi keperluan rakyat yang memerlukan. So in actual fact, in terms of limits and treatment and care, it's my dream to see Malaysia, Sarawak should start first, insyaAllah, but untuk mengadakan pusat diagnostik dan terapeutik yang berpatutan fokus kepada keluarga berpendapatan rendah dan menengah. So every government agency, every ministry, every stakeholder, dia kena memacu usaha untuk memenuhi keperluan segmen ini. Dan ketiga adalah strengthening governance and leadership. Sebelumnya saya sebut tentang having a Sauron-like being, kerana kita kena pantau, tapi lebih penting lagi mengintegrasikan segala usaha daripada sektor kesihatan swasta dan juga kesihatan awam, ya, because we do have a national cancer control plan and it's ended in 2020, the National Strategic Plan for Cancer Control Program. But I think, Prof. Aisyah mentioned before, dia kena ada 3 dekad punya rancangan. Jadi akhirnya dalam 3 dekad, kalaupun penambahan pesakit kanser itu berlaku, tapi kita bersedia dengan kejutan tersebut. Jadi akhirnya saya harap kita dapat memperbaiki usaha bila ada gandingan semua pihak untuk juga mengira kesusahan sama ada survivorship, kemiskinan dengan realistik. So at this moment in time, I don't think we're measuring poverty in a realistic manner, and poverty is also related very deeply dengan pesakit kanser. Mereka jauh lebih tersisih dari segi itu. Ya. Justru saya berharap apa dapatan hari ini dapat kita kembangkan, insyaAllah. From my side, I think it would be helpful if TAC can come up with key recommendations, especially in the lead up to the budget, that can be brought forth or dibawakan dalam oleh ahli-ahli parlimen dan jurucakap, kerana saya boleh tekankan kementerian yang paling penting sekarang selepas pandemik bukan Kementerian Pertahanan, walaupun saya tak kesampingkan kepentingannya, adalah Kementerian Kesihatan, Kementerian Wanita. Dua ini harus menjadi, dan pendidikan, of course, but mereka semuanya harus menjadi cabang utama yang kita perjuangkan, kerana itulah yang menjadi kayu ukur kejayaan dan kehebatan negara kita. Over to you, Julanda. Sorry for the over time limit.
No, terima kasih. And I think that's a wonderful rumusan of all the issues that we tried to cover today. Dan saya harap bahawa ini akan menjadi titik permulaan kepada kita terus mengadakan conversation, dialog dengan multi-stakeholders untuk mencari jalan penyelesaian dan untuk memastikan bahawa kita boleh memastikan tidak ada kanser ataupun pesakit kanser yang tercicir, because ultimately we need universal healthcare access for cancer care in Malaysia. So thank you so much for that. And I think with this, I'll hand over back to Prof. Aisha and Mr. Wong to maybe wrap up. I think we actually over time, so we probably don't have time to go through questions, but I hand over to them for the conclusion and the wrap up. Thank you very much to all our speakers.
Thank you, YB, for those very precise numbering of issues that we will have to focus on. And we have Mr. Wong Kwan Sing, our president of Together Against Cancer. He will tell us what has been learned from the process of today, the speed dating and your rumusan, and what as an advocacy group, Together Against Cancer, can help to maybe voice out the issues that we have. Mr. Wong, are you there?
Okay, thank you very much. For those who don't know me, my name is Wong Kwan Sing. I am one of you guys. I mean, if you are a survivor, I have prostate cancer, and I'm also a president of the Prostate Cancer Society. Okay, welcome YB Nurul Izzah We are very delighted to have you taking part in this forum. And also thanks a lot to Prof. Aisha and all her colleagues for organizing this wonderful forum. And we learn a lot. And we hope that by a summary of this, we can, if YB Nurul Izzah can, or Prof. Aisha can really just summarize the points by what we learned today, and we can get something done. I have met, with a lot of these government officials, including the Deputy Director General, who is directly involved with cancer. And I thought in the previous Harapan government, I talked to the minister and deputy minister, and we got some work done, and especially on generic. And we are so happy that there was some progress, but we like to continue. Okay, anyway, but what we learned today is quite good, because we know, especially from Yokling, that she opened our eyes that indeed, those big farmers can really play with monopolies more than 20 years. And some of them on the trade secret things, and they can even go for a longer time. But what we also learned, that the first guys who got the generic can play with the monopoly as well. And we can take them, to court on that, and hopefully we can get a change. But we did it a very good thing in prostate cancer. We managed to, with the help of as I said, the ministers and deputy ministers before, we managed to get one of the targeted drug, very important for survivorship of prostate cancer, for 2 years, survival for 2 extra years, and that is arbitron acetate. And we managed to get the monopoly off, and then unfortunately, the first company that manufactured or brought in the generic kept the price very high. But once we managed to get the second one in, we managed to get it down way low. And especially, we put our Prostate Cancer Society members, and they get even much cheaper. So I hope that we can work on what we heard from Crystal, that we can do the same thing with Herceptin. And this tetracycline, I don't know the chemical name, but the generic name, now for saving 30% is not good enough. So we have to fight very hard, especially try to get somebody, to manufacture a second one, or how we can work with the government or with the manufacturer to get it more affordable. Saving 30% is still not good enough. I don't know about breast cancer, but if it's effective in saving lives and prolonging life, I think everybody should benefit it, not because of the cost. I'm really very passionate about this, because I used to complain a lot to all the people that I met, especially the politicians, the ministers and all that, saying that, it is immoral, that some drugs, they are really can extend our survivorship. I'm so upset that, for prostate cancer, for instance, I am sure it's for breast cancer as well, that some of the targeted drug can easily extend the lives of our patients, our Malaysians. And just because of money, and also because our government who cannot afford to pay for that, because we signed the WTO, the act that we are prevented to use generic, and that can be easily accessed from India, and that is only 1/10 of the price. Why? Why kill our people? It's a small act, and there are so many things that we can do just to tweak a little bit through the Customs Act or whatever. We can save a lot of our Malaysian life without really expending a lot of money. It's a political will. I'm very, very upset about that, because we fought very hard for it. And I think for prostate cancer, we are okay. I think we can at least extend the survivorship. And I want to do that for all the HER2 positive patients as well. That is the next target.
30% discount is not good enough, you know. So anyway, that is Yok Ling, and I learned a lot from Yok Ling, and I hope that, you know, we can take a lot of her ideas, a lot of what we learned to really work something on that. And I'm very glad to hear from what Deborah Henry and Siti Aida who have done for the refugee. I think they've done a very wonderful job. And I must say, I must take into notice what my fellow survivor, Crystal Ng. I think she did a wonderful job. And she suggested, why not move the income tax relief? Brilliant, I think. And then partnership with a pharmaceutical company. Now that one, we have to dream on, because those guys are for maximum profit. And the thing I love what he says is that I'm really a victim of that. I used to work for a big company. And I used to work in the States. We have, when I was in the States, we have a system that after retirement, there is an insurance plan. You can really pay very minimal contribution in which you're covered. It's exactly what Crystal said. That, you know why? Because we thought that I retired. I was very lucky. I retired at 70 years old. So what happened? I just don't care. I don't buy my insurance. And after that, you're not qualified. So most of those guys who retired in Malaysia, maybe after 60, and they're not covered. And then we never bothered to buy insurance before I was 60 years old. But in my case, I worked until I was 70 because I was in a senior management. But anyway, okay. The other thing is that I'm not that financially problematic that I cannot afford that. I cannot use my money for cancer treatment. But then, you know, as Crystal said, that our M40 is also squeezed in the middle, as Nurul said, you know, that we are not protected here and there, and we suffer substantial financial toxicity. And I think it is great if we can work harder, you know, TAC and so other NGO, to say that, look, we make the company, you know, especially big ones, that they should somehow or rather negotiate it with their insurance company. Some of the big companies have big companies packages, and to force the insurance company to continue the insurance after retirement. A brilliant idea, you know. And the other thing is that I'm also very impressed by Cecilia, who did a lot of work on Sarawak and Sabah. And by the way, I used to work in MIRI for about 5 years when I was just started work with Shell in the oil fields, you know. And I know how big disparity between the urban area and the rural areas. Of course, now I travel all over Malaysia to support our prostate cancer all over Malaysia. And I'm so disappointed that I tell you something, even as close as Ipoh doesn't have a residential urologist. I mean, such a big state, Perak, you don't have even one specialist to be residential. And Sarawak, you know, you have one hospital in Kuching, and that one has one urologist, Dr. Tekon Chow. And the whole state, my gosh, of course, they have a couple of private ones just floating around. And it is so pathetic. And so with Sabah, there were only one, you know, one urologist, special consultant for the whole state of Sabah. So I'm so glad that you brought it up, and I hope that you guys also fight very hard, that there's a big disparity. As you said, there were 1.8 or 1.9 million of East Malaysians who are really deprived of proper, similar type of Malaysian Malaysian medical treatment. And I think we should pull our socks up and try to work hard to improve our healthcare system. And not only the healthcare system, also because I'm also a beneficiary of, you know, of the, as you said, the family, what do you call the clinics, you know, that every 6 months that I go. But what I found out is that really the doctors are good, but those guys who are working in the front line, for receptionists and all these guys who quite queue, they treat you as if you are beggars. You know, they think that you come in, you are benefiting the government services, and that you are beggars. And every time I go there, I have to say, look, you know, to the specialists, say, look, those guys in front are just treating like all of us are beggars, you know. And I think you should improve on that. And sometimes it helps, and sometimes it doesn't. Okay. So anyway, we really thanks a lot for YB Nurul Izzah to be here. And I hope that Prof. Aisha can make a synopsis or summary of this.
Yes.
And hopefully some of our points are taken.
Yes.
Yeah. And we hope that you know, some reaction will come from Parliament. Okay. Thank you very much. Thank you very much for everybody.
So I think we will just need to wrap up very soon. So lastly, I think we have heard from everyone, and YB, you are our voice. I know you're ambassador for some cause, and I hope you will take up the cancer as a whole, as a cause. And you can see how women's health can be brought together. A lot of times we take things into silos. Maybe cervical cancer should be paired with breast cancer when we're talking about screening. And of course, the finance aspects, we have all discussed about it. So YB, any last words? Because we might wrap up just after.
Yeah, thanks, Prof. Just a short one, because from my sessions with a few doctors before this, and I'm still learning, so it's been really a wealth of knowledge over the sessions. But some screenings offered by private hospitals also don't include the gold benchmark, which is the HPV screening. So when you talk about even the right test, right? We have to ensure they pay and they get their money's worth.
Exactly.
So knowledge is very, very crucial. That's one. And number two, we need to get everybody to push this agenda, because I think even the Ministry of Health, that, you know, themselves, they're struggling in the context of business as usual approach by the budget versus post-pandemic requirements, which really seriously, you know, has to be done to fulfill the needs of cancer patients. So, yeah, no pressure, everyone. But it's our collective pressure.
For sure, we are seeing it in the clinic.
Yes. So it's a collective pressure because it's our lives at stake. So no, our loved ones, I think we're all in this together. It's just that, you know, I will share with my colleagues, but a summary of today will be crucial, will be important. Thank you, Prof. and Yolanda and everyone who have kindly spent your time today.
So thank you, everyone. Yolanda, any last words? Or else we will wrap up. I think we had a wonderful session, a learning session, a speed dating session, as you mentioned.
No, absolutely. So yeah, thank you, everybody. And we look forward to taking this dialogue forward.
Shout out to all the organizations that supported this movement. We also have people from SCAN, from Sarawak, Sarawak Cancer Awareness Network, which will be supporting, right, Yolanda, the activities we're doing in Sarawak for the month of October and November. So there are so many organizations. All we need to do is to work together. With that, I think we will have to stop here. Thank you so much for everybody for coming over, sharing and spending time to learn more so that we can be more effective in the future. So thank you, everybody.
Thank you very
Goodbye.
much. Thanks a lot.
Bye.
Well done, well done.
Get some
Thank
rest,
you,
Yolanda.
thank you.
The time
Well done,
is
well done.
killing you.
Yolanda, go
Thanks a
back.
lot,
Go to
YB.
sleep.
Good
Go
night,
to sleep.
Yolanda.
Go to sleep.
Take care, everyone.
Get them to you.
Come back again. Come back again.
I'm going to bed now. Good night.
Sleep well.
Good night.
Thank you.
Bye. We forgot a photo lah. Yeah, Hamiza, I hope you did take a photo.
I have taken, don't worry. I will send you. I taken a lot of. I snapped